I think the House legislation that we've seen so far and the drafts of the Senate legislation from the Senate Finance Committee that we saw earlier all include pretty aggressive pursuit of pilots on all of these dimensions, whether it's medical home payments for primary care, essentially bundling payments to support strengthened primary care or accountable care organizations, or bundled payments and readmission payments.
But then there's all these other possible approaches that people are suggesting. So one that is very much on the table is the idea of a public option for insurance coverage.
The important aspect of a public option is, will they regulate rates that are paid to providers within the public option, as is in the House legislation? And that's among sort of the thinking people in this fight what the battle is about. The less important part is who owns the plan. Is it GovCare or Aetna? Well, the truth is they're paying competitive private rates. It doesn't really matter that much.
So does paying providers less change the cost of the system?
If the public option could come to the table with a reform payment system, a radically different payment system, and perhaps not contract with every provider, allow certain accountable care organizations and others to come forward, it could perhaps innovate in a way that's just not possible based on the way health plans compete in our system now.
Although we don't necessarily need a public option to do it. We have for the Medicare population a large population that is very interested in some of these in some of these new ways of paying.
The problem is, politically, we've tried Medicare pilots and they get killed. But if this legislation could bring the hammer down and say, no, we are going to have these pilots, even if local politicians don't want them, we are going to have these pilots, then that would be a very significant step forward. We have a goal we'd like to achieve, which is to bring our healthcare costs under control in a sensible way. That's a goal that we don't know how to achieve yet.
What about the argument, though, that we do know how? Single payer. If we had a single payer system, this would control our costs.
I mean, I think if you just look at Medicare today and all you did was expand it to the rest of the citizenry, then we'd still be facing the same problems that we're facing now. So I think, again, we need a shift in social decision-making around healthcare. And I think there's been some conversation about creating an entity that would be somewhat politically insulated that could make and really implement decisions about reform. An entity with the legitimacy to guide the country towards making more reasonable trade-offs in terms of how much and what we want to spend our healthcare dollars on.
There are more optimistic visions of what a single payer might do, become an aggressive supporter of reorganized and improved care. That's a different vision of what a single payer might be like, one that I could be attracted by.
The other point of view is that we should really be heading in the direction of creating medical savings accounts where people have high deductible healthcare coverage and they have some skin in the game, as the economists like to say.
Well, first and foremost, we have lots of evidence that when people pay out of pocket, they don't make terrific decisions about what to seek and what not to seek. And second of all, because of the nature of insurance, we need to protect people against catastrophic risks, against high costs. This cost sharing would be limited to the end of the distribution of healthcare spending that matters least. So what is driving high and growing healthcare spending in the U.S. is in the tail of the distribution. Very high cost interventions and very sick people, and cost sharing is totally inappropriate there.
There's no one who thinks seriously about this that thinks that a consumer-based approach can control costs in a fundamental way. I mean, ultimately, the supply side is where it has to happen. Physicians make the decisions, hospitals make the decisions. Consumers can't shop from the back of an ambulance of where to get treated for their heart attack. That said, I think it's very important to recognize, to learn from the lesson of the managed care backlash. I think the fundamental lesson there is people didn't see the savings. We had 3 years where healthcare costs grew by, employer-sponsored premiums grew by 2% or less a year, which is amazing, below inflation for 3 years in the late 90s. But people don't know that. And unless you give people a financial stake in what's happening, there's going to be a backlash against accountable care organizations just like there was against managed care.
There are a number of provisions that would come in as a part of health reform and make a difference in care. You mentioned one early on, comparative effectiveness. Exactly how does someone doing research in Washington on whether one statin or another statin works and having a result 5 years from now, how does that translate into savings, or am I misunderstanding what comparative effectiveness really is?
I do think, in general, we have a grave lack of head-to-head evidence on the effectiveness of clinical interventions. And without that information, commercial payers in particular, but also Medicare, really lacks the ability to try to impose rules that might improve the value of healthcare spending.
As a clinician, it would be wonderful for us to understand better what the real risks and benefits of these treatments are so that we can help our patients make wiser choices. And that's the fundamental issue. Lung reduction surgery for chronic obstructive pulmonary disease, if it doesn't work, gosh, we really shouldn't be doing it. So the other thing that's missing from the comparative effectiveness discussion is that we really need to be understanding the effectiveness of different delivery systems and different approaches to delivery, because that's where the real opportunities for both improving care and reducing spending are.
This is actually almost certainly a no-brainer. It's just impossible to argue that more information here wouldn't be good. And I think the notion that, somehow making the information available will turn the government into Big Brother is just crazy within the context of our political system. Right now, we are so far away from Big Brother. We are so hands-off. We do so little to really talk about what's effective that we can only move in the right direction at this point.
I'm suspicious we won't have enough information in the next 5 or 10 years to actually make a significant dent in the system. We will always have to be making decisions in the gray zone, even with comparative effectiveness. I mean, can we claim billions and billions of dollars from the research that will come out of this?
I think it depends on, I agree with you. Judgment is essential. This information, especially treatment A versus treatment B, is not going to dramatically deflect the growth of healthcare spending.
Especially when it shows us that the 10 times more expensive treatment A was better.
Now, probably it could increase costs.
Maybe you do learn that the 10 times more expensive treatment A is better. Great, then do treatment A. As long as the public understands its costs and we understand its effectiveness, then super. Then let's do that. The problem is neither's true today. Both those need to be addressed. And it's never going to take out the huge share of decisions that are gray zone. But look, even a tiny, tiny effect on the growth rate is billions and billions of dollars over time.
We see huge differences in growth rates across communities. Right. So, you have San Francisco, San Diego, Central Pennsylvania, many other communities around the country, Tallahassee, Richmond, Virginia, where cost growth has been at least a percentage point below the national average. And no one in those communities is aware of rationing. None of the physicians in those communities would say we aren't providing the beneficial treatments. So the kinds of deflections that we need to achieve trillions of dollars of savings are relatively modest, and they're mostly going to come, I think, from reorganizing care delivery, not from eliminating beneficial and wanted care.
What do we need to see coming out this year, and what might happen if we don't?
I really think what we need to see coming out this year is coverage. I think that even if this bill fails, I think cost control is a longer run battle, of which this is just a very small part. The critical part is about covering the uninsured Americans. It's our moral obligation to do so.
I think passing coverage, it may be critical in part because it's an opportunity to be giving with one hand and asking with the other. And so giving to the pharmaceutical industry, giving to the insurance industry, and asking for reform, for changes in the way these private entities, which have such an important role in our healthcare system, do business. And I think without having that authority, it's going to be hard for the federal government to begin us down the road of cost control. So I think it's a political balancing act, but I think that coverage creates an opportunity.
Well, I think it would be a tragedy to miss this opportunity to expand coverage, in part because it helps fix so many of the problems that John and Meredith have identified with the health insurance system. I think the cost issues, I agree, are a longer-term issue, but gosh, it'd be too bad to miss this opportunity to get our children covered.
Well, thank you for that important sum up, bringing back how the coverage fits together with the costs. This is an important moment for the country, a vital debate, and costs have been in the center of it in part because it is the question of whether we can afford that coverage for everybody. So thank you, and thank you all from the New England Journal of Medicine.